Well, thank you very much for coming this morning to this meeting. This is always a very interesting meeting from an oncologist standpoint in the fact that more than 5 years ago, lung cancer doc would never think about coming to an immunotherapy meeting. But now I think we've proved everyone wrong that immunotherapy does have a role in the treatment of lung cancer, and certainly things are changing. I'm going to briefly go through lung cancer, and please, I'm trying not to be data heavy. I'm a scientist, but again, please bear with me. I want to show you kind of how we got to where we are, what drugs are available on the market that your doctor can prescribe for you, and really where this field is going and how we need your help to try to make immunotherapy more applicable to more patients with lung cancer. Because even though we're excited about the results, we want more. So immunotherapy agents do have a promising anti-tumor activity in non-small cell lung cancer, but this past year at ASCO, we also have some data in small cell lung cancer. Immunotherapy is now a reality for patients with metastatic non-small cell lung cancer. But as Dr. Lipson talked about before and others, these agents do have a unique set of side effects that some oncologists are not used to taking care of. And so we have to help educate them, and certainly you as patients do have to pay attention to side effects. And in fact, some of my patients have said, hey, I saw the Opdivo ad on the TV and I have a cough. What should I be worried about that? So, it's been very helpful to have patients very in tune to their therapy and trying to also watch vigilantly for side effects. And then lastly, I'll talk about this much more in the next session. Biomarkers will be a key, we think, to really further this field and develop who should get a single agent immunotherapy and who should really get combinations. So, but I don't want to forget about vaccines. Don't forget about this. In the past, in lung cancer, really, vaccines have not shown a promise for improving survival in patients. However, I think we're going to be able to resurrect these types of therapies because of the immune checkpoints. And just to briefly remind you, we all know what vaccines are supposed to do when it comes to infections. We get vaccinated with typically an attenuated virus or bacteria, and along with a medicine called an adjuvant to stimulate your immune system and response. And so the goal is to develop T cells that remember that bacteria or virus. But we're trying to do this with cancer as well, either injecting a protein that we think that's abnormal in a lot of cancers, and then combine it with something that, again, stimulates your immune system. And the goal is to try to activate T cells and also to promote memory in your immune system to remind the immune system when a cancer cell comes up that it'll attack that. But unfortunately, as you can see right now, there's been the first three vaccines have not shown in general that they improve survival in lung cancer. But the middle one, the BLP25, recently was published. And while it did not show an improvement in survival in the whole group of patients, this vaccine was given after chemotherapy and radiation. It was found that in the subset of patients who got chemotherapy and radiation together, that it did improve survival. And so they're going back to do a large study just in patients who get chemotherapy and radiation at the same time to really show, does that really improve the survival? And I think it will, but this trial is ongoing. The last two, the EGF vaccine came out of Cuba and is approved for use in Cuba, is being or will be evaluated in the US up at Roswell Park, and that trial will be ongoing soon. So that trial is very exciting. Again, they have, the company out of Cuba has worked on trying to figure out biomarkers in patients that might benefit from this type of therapy, but it is not yet approved for use in the US. There's another TG4010, another protein-based vaccine that trials are ongoing internationally. But I think we're most excited about this vaccine technology is really improved over the past several years since all of the excitement about immunotherapy. And I think the vaccines are going to be, that are being developed will actually show better promise than what's been tested so far because of that improved technology. But all of these vaccines are very early on in development. They're phase 1 type of trials, but they're coming. So, but what about ipilimumab? It's not just for melanoma. We know that ipilimumab, which blocks the CTLA-4 checkpoint, which actually helps put the brakes on the immune system. So if you give the ipilimumab, this antibody, it unleashes the brakes in one way. So I wanted to start with the antibody that was first approved for use for any cancer. So, and we know that it improves survival in patients with melanoma. And in lung cancer, it has been studied when combined with chemotherapy. And initially on, this did show promise when combined with chemotherapy, but we have yet to hear the results of a phase 3 study when ipilimumab was combined with Taxol or paclitaxel and carboplatin, and we're awaiting these results. This trial was finished accrual in 2014, and we're still awaiting results now. So I'm not sure whether or not ipilimumab will be additive to chemotherapy. And I think it kind of just gives a chance to talk about, we're not sure how these types of agents combine with chemotherapy. One thought is that chemotherapy might unleash the proteins by killing off the cancer cells, and so the immune system can recognize those proteins maybe a little bit better. And then allow these types of antibodies to, again, help unleash the immune system even more. But we're not sure. We know that chemotherapy has to be given with high-dose steroids sometimes. You guys might have needed this as well. Taxol, you have to get a very high dose of steroids to prevent side effects from that type of therapy. Plus, steroids are great anti-nausea medicines as well, but we think steroids may actually dampen the immune response. So we're not sure how best to give these types of agents with chemotherapy. Ipilimumab was studied with small cell lung cancer and the standard chemotherapies that are given right up front when a patient is diagnosed with small cell, but in this trial, ipilimumab did not add to chemotherapy, and so it's not being developed any further. Now let's get to the meat of the talk for the PD-1 pathway. We have, as they talked about earlier today, blockers of the PD-1 pathway. Either these antibodies bind to the receptor on the T cell, the PD-1 antibodies, or they bind to the ligand PD-L1, which tends to be either on the tumor cell or like a dendritic cell that does help promote T cell response. By blocking this pathway, again, we're taking the brakes off the immune system. We're not putting on the gas, we're just taking the brakes off the immune system. So, and this is a full, not a full list of drugs that are being developed in lung cancer. The top two are the PD-1 antibodies, Nivolumab, that was first approved by the FDA, and just recently pembrolizumab, or Keytruda, was approved for patients with PD-L1 positive lung cancer. PD-L1 antibodies are a little bit not quite as far along. They're finishing up phase 3 trials. Atezolizumab is probably the farthest along and has an FDA fast track designation. So we hope to hear some of that data soon. The MEDI4736, some people call that durvalumab, but that is currently in a phase 3 trial, and then others that are just numbers are in phase 1 and 2 trials. But you name the company, they're developing these antibodies to try to really develop them to be able to combine with other therapies. But, yes? Mm-hmm. So it's a PD-1 antibody, but I'll actually explain it in this part of the talk to explain how it got its FDA approval. So let's go over briefly the studies that led to the FDA approval of the PD-1 antibody. So those are the drugs that we have available: Opdivo, as well as Keytruda. Opdivo is also known as Nivolumab, or Nivo as we call it. Keytruda is called pembrolizumab, or Pembro as we call it. My patients are very excited to say, actually, at least some of these, you've been seeing some of these ads on the TV, and so one of my patients said, at least now we can compete with Cialis. Yes. Finally, lung cancer gets their day. So this was the study that led to the Opdivo's approval in squamous lung cancer, and so this was the first immunotherapy approved for lung cancer. In this trial, how it got approved was looking at patients who have metastatic lung cancer, who had previously received chemotherapy for first-line treatment, and now their disease has grown, and so they're looking for the second type of therapy. And so this is for second-line treatment. And patients were either given Nivolumab, I don't know why today I can't, because I talk about this every day. This is given once every 2 weeks by vein over an hour, or they receive what is standard still, docetaxel, and that's the standard chemotherapy in the second-line treatment setting. And that chemotherapy is given once every 3 weeks. The goal was to show that Nivolumab actually improves survival. And they also looked at tumor response, and they also wanted to look at the biomarker. If your tumor has PD-L1, does that improve or increase the chance of benefiting from Nivolumab overall? So, and the results showed that Nivolumab improved survival compared to those patients treated with docetaxel by about 3 months. So it's 9 versus 6 months. And so that is an increment improvement, and it actually doubled the 18-month survival. And why we're showing this, that it doubled the 18-month survival. In the past, when docetaxel got approved back in 2004, they weren't even talking about 1-year survival. And so now we're talking about 18 months survival, and we hope over the next year we're reporting 2- and 3-year survival. So we do think that this is a significant improvement. So in the response rate, when we're talking with a patient, the response to docetaxel, we say, is about 10%, and the same for pemetrexed by itself. The response rate is about 10%, so 1 in 10 patients, their tumors will actually shrink down. For Nivolumab in this setting, that basically doubles about 20%. So again, it's not great, but it does significantly improve on what we know. The exciting thing, though, which is different than chemotherapy, is that when you respond, the response lasts a long time. And in fact, it had not even been, the median time of response had not even been reached at the time that this was published for patients treated with Nivolumab. But as you can see, for docetaxel, the response median was about 8.4 months. So again, if you respond, you tend to respond for a decent amount of time, but nothing compared to if your tumors respond to Nivolumab. And again, in the past, we thought, oh, it takes a long time for immunotherapy to work, and that we really have to wait a long time to see. But actually, the time to response is very similar to chemotherapy. We should expect in about 2 months that about 50% of patients, their tumors will decrease at that point. So stable is good at 2 months, but if you get a response at 2 months, we would hope to expect at least half of those patients, if you're going to respond, you'd respond at that time. For melanoma patients, there is a lot more information about what's called pseudoprogression. And so you can see here, only about 28 patients on the Nivolumab arm were treated beyond what we call RECIST-defined progression, if a new lesion occurs or if your tumors grow significantly. But we did see this non-conventional benefit, or what we would call pseudoprogression, where your tumors increase in size or a new tumor occurs and then things decrease over time. About 9 out of 28 patients, this actually did occur. So it's not that common in lung cancer compared to other cancers, but typically at that 2-month period when we look at your tumor on CT, if you're feeling really well, but your CT doesn't look great that it's growing, we are more willing to step back and give you two more months of treatment to see will your disease actually respond at that next time period. Now, if you're not feeling well, if you're having a lot of side effects, not just due to the drug, but side effects which we think are due to cancer at that 2-month period of time, we're more likely to go on to some other therapy because we don't want to risk the chance that your disease will continue to get worse. So then what about PD-L1 expression? And ignore the left side and actually look more to this. So down here at the bottom, so to try to explain this, so PD-L1 expression, the black dots are if the cancer stained positive for PD-L1. So this gets to your question. So if your cancer stained positive PD-L1, those patients are in black dots. If your cancer was negative, had negative expression, those are the red spots. And then the gray spot was that we didn't have enough tumor tissue to do the testing on, which is relatively common, occurs about 25% of the time. So we looked at various different ways to call the tumor positive or negative for PD-L1. And we tried to equate that. Did that associate with survival? And that's what OS means. And if you look at the bottom, if the line is on the left-hand side for Nivolumab, that means that the tumor, positive or negative, did better if it was treated with Nivolumab. And if it's on the right-hand side, on the docetaxel side, it means that positive or negative did better with docetaxel. As you can see here, no matter what level of positivity that you look at, tumors that were positive or negative actually responded better and did better overall with Nivolumab. So in patients with squamous cell lung cancer treated with Nivolumab, we do not check PD-L1 in their tumor because right now, with this test, with this antibody, we don't think it matters. There's an equal chance of responding to Nivolumab no matter what your tumor biopsy shows. So what about side effects? The nice thing about Nivolumab compared to docetaxel is that it does have less side effects. And actually, we call the significant side effects that we have to treat with steroids or other medicines that are called grade 3 and 4. Any grade includes even just slight side effects or bad side effects. But as you can see here, 86% of patients had any grade of side effect when they were treated with docetaxel, compared to 58% if you were treated with Nivolumab. And then significant side effects where we were concerned that you might need treatment, 55% that experienced that with docetaxel, or 7% experienced that with Nivolumab. And so in general, we think that Nivolumab is easier to tolerate than chemotherapy, and those of you who are on this type of therapy probably can attest that. Now, this is the trial that now led to non-squamous. So in March, the patients with squamous cell histology of lung cancer could receive Nivolumab in the clinic, not just on a clinical trial. And that started in March. And up until this fall, the FDA had not yet approved non-squamous cell histology until this trial came out that looked at Nivolumab versus docetaxel in patients with non-squamous cell histology. So that means patients with adenocarcinoma, large cell carcinoma, and others that are less frequent, and those patients are all lumped within non-squamous. This trial did not include small cell. And again, the goal of the trial was to show improvement in survival. And again, Nivolumab improves survival, again, by 3 months. And so in patients with adenocarcinoma or non-squamous, the overall survival increased from 9 months to 12 months, and this is median, again. And it nearly doubled the 18-month survival as well. So we're, again, based on this, the Nivolumab was also approved for non-squamous cell histology. And so at this point, patients can receive, with lung cancer, can receive Nivolumab in the clinic. Again, increased response rate, very similar time to response. And again, the duration of response, instead of like 5 to 6 months, is now more like 17 months. So again, if your cancer responds, it responds for a very long time. And that's, again, is median, because we have some patients who have been on treatment for years. Again, you can see tumors respond or progress first and then respond. That occurred about in 20% of the patients whose disease looked worse on the first scan, but then improved over time. So not that common, but it can occur, and so your physician does need to know about that. So we looked at various different subgroups of who responds and who doesn't respond in this trial of patients with non-squamous cell histology, and we tried to look who was more likely to respond based on characteristics. And it seemed not to matter what age, so someone who is elderly versus someone who's young, you could respond. If you were a man or a woman, it didn't seem to matter. You could respond equally. If you were had minimal side effects from your cancer or other diseases, you could respond. But interestingly, we saw that in this trial, as well as other trials outside of this, that if you had a smoking history, you were more likely to respond than if you were a never smoker. And this kind of going along with that, if your cancer harbored an EGFR mutation, one of those mutations that you can receive erlotinib, Tarceva, or afatinib, or even Iressa, you were less likely to respond to nivolumab. And actually, as you can see down here, again, sorry that this doesn't work, that you actually might do better with chemotherapy, or at least very similarly if you got chemotherapy or nivolumab. So in this group of patients, actually, when a patient comes in to see me who's never had a smoking history or has an EGFR mutation and has progressed on the, like Tarceva, I actually recommend a biopsy for those patients with EGFR mutations and see, does that cancer actually harbor a T790 mutation, where I'd prefer that patient to go on to a T790 inhibitor rather than immunotherapy, because I think the chance of responding to a T790 inhibitor would be much higher compared to nivolumab. As well as a patient who's never smoked. While you could go on nivolumab and actually do about as well as getting chemotherapy, I'm more likely to try to get that patient on a clinical trial of combination therapy to try to increase the chance of responding. So what about PD-L1 expression in this group of patients with non-squamous? And so it was looked even more, and I think the interesting thing, if you look on the left-hand side all the way to nivolumab, the response rate in this group of patients was different than squamous patients. So here, the response rate, if your tumor was PD-L1 positive, was higher, 30-some%, okay, compared to the overall 20%, compared if your tumor was labeled negative for PD-L1 expression, where the response rate is about 10%. So there is a difference in response here in this group of patients, which is different than squamous cell lung cancer patients. And so that is why it is very controversial in this group of patients, should we test those patients or not? But as you can see here, over here, the duration of response, if your cancer responds to nivolumab, if it's positive or negative, it responds for a long time. So we don't want to exclude patients who have tumors that are negative, because if you respond to a long time. So we don't want to exclude those patients, but yet we have to manage expectations. The response, if your tumor is negative, is much lower compared to if your tumor tests positive for PD-L1. We also looked at survival, and again, in this group of patients, it's different than squamous. Again, if your tumor was PD-L1 positive, your survival was much better if you received nivolumab compared to docetaxel. Now, if your tumor was negative, your survival was equal if you received nivolumab or docetaxel. So based on this data, again, sitting in front of a patient, if I happen, again, I'm not as concerned about getting PD-L1 staining, but it does help talk with someone about whether or not to receive nivolumab or chemotherapy. If your tumor stains positive for PD-L1, again, you're more likely to do better with nivolumab. But if your tumor is PD-L1 negative, that's when I sit down and say, okay, your survival is going to be the same if you receive chemotherapy or nivolumab. Nivolumab does have less side effects, so we go through the different side effect profile and decide from a patient perspective, what sort of side effects do you want to avoid? Sometimes schedule comes into play about how often you have to come into clinic. For Nivolumab, you're coming every 2 weeks. For this type of chemotherapy, you're coming every 3 weeks. So if you're traveling a long way, some patients like to only come in every 3 weeks. For some people, again, docetaxel causes hair loss, so they don't want to lose their hair, so they prefer to receive Nivolumab, or they have various different reasons why they wouldn't want chemotherapy, so we do talk about Nivolumab as well. So it's just the PD-L1 expression, while it may increase the chance of benefit from Nivolumab or this type of immunotherapy, it does not 100% say, hey, you should not get it. It just says, well, the chance of benefit is equal to chemotherapy. But again, it's weird. It's different depending on the subtype of lung cancer that you had. Again, just in general, side effects are less with Nivolumab compared to docetaxel. The most common side effects, as Dr. Lipson talked about, was fatigue, but we can see endocrine issues, GI issues, much less compared to ipilimumab, but we do have to monitor patients differently. Rash certainly is common, as well as less common is liver problems or kidney problems. So the pembrolizumab, or Keytruda, the trial that actually got it approved was just a very large phase 1 trial. So this is completely different. And a lot of the work that the folks did trying to develop pembrolizumab was based on PD-L1 staining. And they looked at various different levels of pembrolizumab treatment in patients with lung cancer. They looked at patients who had been previously treated and who had never received treatment. Their primary endpoint was trying to increase response rate and really finding a group of patients that did extremely well with pembrolizumab. And this graph shows the PD-L1 expression in patients' tumors and how much percentage. So on the far left, the PD-L1 expression is less than 1%, and that's flat out negative. That's the largest group of patients. About 40% of patients on this trial had PD-L1 negative tumors, and the response rate, again, very similar to Opdivo, around between 5 and 10%. Now, if you go all the way to the right-hand side, where the highest PD-L1 expression of the tumors, not very common, so between 15 to 20% of patients on this trial had very high expression of PD-L1, but as you can see here, the response rate in that small group of patients was close to 50%. So that, as well as if you look at the next group of bars off from the right, 50% to 75% expression, again, not very common, but the response rate was between 30 and 40%. So based on this data and based on PD-L1 staining and because of the response rate being close to 50%, Keytruda received an approval from the FDA recently. It's approved for use in the second-line treatment setting and beyond in patients whose tumors stain for PD-L1, at least 50% of those tumor cells on that slide. So again, raising the bar for receiving this type of therapy. Again, if you have a high expression on the tumor, then the chance of response is quite high. This type of test is available. Your oncologist can order it. And to receive pembrolizumab, you have to have the test be positive at least 50%. That's what they're telling me, and it is FDA approved. So, but we'll talk in the next session that not all of us know when we receive a test back what antibody was used and what level of positivity was used. So that's definitely a question that we have to ask. So, and again, in this group of patients, if you had never received any type of therapy for your metastatic disease, the median survival was about 16 months. And again, this has not been compared to chemotherapy head-to-head yet, but that is quite exciting because, again, in the past, the median survival was about 12 months for patients who were just diagnosed with lung cancer who did not have an EGFR or ALK abnormality. In the second-line treatment setting, it's great to see that there's consistent data of a median survival about 9 months when you're receiving pembrolizumab. But again, the large phase 3 study had not been done yet, and we, at least per press release, there's very consistent similar activity compared to Opdivo when comparing it to docetaxel, the chemotherapy. So this is all the summary of the data, and you can look in the slides. I just wanted to, some people are data-driven and want to know numbers, but I don't want to forget about the PD-L1 antibodies, atezolizumab and MEDI4736. There's a lot of studies ongoing with both of those drugs. Those drugs are not yet approved by the FDA. Very similar activity in a lot of the trials that are currently being done compared to pembrolizumab or nivolumab, but there's never been, not yet, a head-to-head study between those first two, nivolumab and pembrolizumab, versus these drugs. So we don't know, are these PD-L1 antibodies as good or better? Are they truly less toxic or not? And how do they compare to chemotherapy? And we're awaiting a lot of these therapies as well. So we'll see. Again, I think we're looking and seeing that, again, from a side effect standpoint and a response standpoint, it looks very similar. So what about, we talked about the never smoking versus smokers. I don't tell my patients to go out and start smoking, by the way. But it's been a consistent story about across all of these antibodies that patients who have a smoking history are more likely to respond to this type of therapy. But why is that? And the thought is that when you smoke or are exposed to carcinogens, the cells actually have a lot of mutations in them. And so the more mutations that your cancer has, the thought is the more chance that there's abnormal proteins being expressed on that cancer cell that your immune system can recognize as being abnormal. The smaller amount of mutations, the less likely that there's an abnormal protein on that cell surface that your immune system can recognize. And so there's a lot of work going on looking at checking all sorts of mutations or looking at the mutation burden in a patient's cancer and seeing if that equates better than PD-L1 testing in cancer. And I'll be talking about that a little bit more. But this seems to be very similar data across the cancers. So what about side effects? I know Dr. Lipson talked about it. Again, fatigue is there. Some patients have it, some patients don't. In general, most of my patients say it's much easier to tolerate than the chemotherapy that they've been on. Certainly rash can be experienced. A lot of times we start with topical treatments. Some patients of mine, if it's really itchy, will try Allegra or medicines like that that are antihistamines. But in general, it's pretty easy to control. Diarrhea or colitis can occur, not very commonly. We do like to start steroids early. We actually do check, make sure you're in and out of the clinic. You do have a chance to be exposed to other infections that can cause diarrhea, so we do check for that when we're looking for trying to decide whether to start steroids. But starting steroids early and not sitting on this, literally, is very important. And then we taper those steroids very slowly. If we taper them quickly, the thought is that the side effect will come back again. Hepatitis or liver enzyme abnormalities can be seen. We can see infusion reactions. Again, it's more common to see when you're getting chemotherapy, but sometimes patients do react to these drugs. Endocrine issues, very common, mainly thyroid issues can occur, and then infrequently, but what we're most concerned in our lung cancer patients is pneumonitis. A lot of my patients who've smoked before have issues with emphysema or COPD, or they may have lung fibrosis from radiation. So we're always worried, what is this? Is it cancer, is it pneumonitis, or is it infection, or is it just problems with the COPD or other factors? And so, this in a lung cancer patient is one that we worry about the most, but it is not more frequent if you have melanoma or lung cancer. It occurs. But severe toxicities are really, in general, uncommon on this type of therapy. Again, going back to pneumonitis, this type of therapy is not the only type of therapy that we give you that can cause pneumonitis. Tarceva can cause pneumonitis in patients. Iressa can cause pneumonitis in patients. Docetaxel or Taxotere can cause pneumonitis. Gemcitabine, pemetrexed, as well as most common cause of pneumonitis in our lung cancer patients is radiation. So, this is a very, it's not common, but when it occurs, we have to think about this all the time. It's just not something that we talk about as much with chemotherapy. So what about small cell lung cancer? And I don't want to exclude patients on small cell, most because there's such a huge patient population. That's where, and some of the initial data went, that's why we started with non-small cell lung cancer, looking at pembrolizumab and nivolumab. But small cell lung cancer is also related to smoking. And the thought is that there's a lot of mutations in patients' tumors with small cell. And so why not look at this type of therapy? And both pembrolizumab and nivolumab are showing responses in patients with small cell lung cancer, which is very exciting. But trials are ongoing right now, and it certainly is not FDA approved. They're also looking at combinations, just like in non-small cell lung cancer, combining these type of therapies with other immune therapies. So what about PD-L1 testing? We talked about this before. This is what your tumor looks like if it's positive for PD-L1. It's the brown staining and the rings around the surface. That's showing PD-L1 expression on the tumor cell surface. And that's what we're looking for if we do PD-L1 testing. So, but there's a lot of questions, and I'll go into this a little bit more, is that each antibody that has been, or test that's been developed with each antibody, so pembrolizumab has its own test for PD-L1, nivolumab has its own test for PD-L1, atezolizumab, the PD-L1 antibody, has its own test with PD-L1. So that's why it's so important for us to know what antibody was used to say that this tumor was PD-L1 positive. So just sending it off to a company and not knowing those things is not very helpful. Because how good is the test? Was it tested in these large trials, or was this just a random test that was developed by that lab company? Are we testing the right cells? We still are debating, is it more important to have PD-L1 on your tumor cell, or also to have it on cells that aren't tumor within that microenvironment, like the T cells within the tumor? Is it important for them to also express PD-L1? So what is important? The question is it one versus the other or both? And that answer has not been found yet. How about how old of a biopsy is too old? If you had a surgery 5 years ago and now you've developed metastatic lung cancer, can we go back and test, and will that truly show us the extent of PD-L1 positivity? We think that probably PD-L1 does change over time, depending on stage and response to prior treatment. And so we do really push for fresh biopsies. A fine needle aspirate biopsy where they just suck out cells to tell you whether or not you have cancer or not is not enough cells to be able to test for PD-L1. You really need to have a core biopsy. So it's called a needle core biopsy, or a biopsy where they go in and take a piece of tumor out. Also, pathologists have been able to show that if you biopsy one part of a tumor, it could be negative in that biopsy, but if you biopsy another part of the tumor, it could be positive. So this expression is patchy typically. Typically, it is on the surface of the tumor where the immune cells are interacting with the tumor. It is not typically in sheets across the whole cancer. And so again, the question is, did we biopsy the right spot? So there's a ton of trials. We're hoping to try to show that for some patients, they never need to receive chemotherapy, that this type of therapy by itself will be good enough. And so in patients with whose tumors are PD-L1 positive, there's various different trials that are ongoing. Some have completed and we're waiting for the results. There's a lot of trials now looking at combination therapy versus single agent versus chemotherapy as well, particularly in those patients whose biopsy does not show PD-L1. There's also more therapies looking at in the second line treatment setting and beyond, but I think most exciting is trying to move these antibodies to early stage. Can we increase the chance of cure in patients with stage 3 disease. So there's a trial ongoing in patients who've received chemotherapy and radiation who then receive MEDI4736 after that. And then there's also trials to look at this type of therapy before surgery. Can we decrease the size of patients' tumors before surgery, and then hopefully down the road improve chance of cure? And then also, importantly, for a group that advances have not shown much improvement over the past 20 years, for small cell lung cancer, there's trials ongoing with this type of therapy as well. So I think the future is really looking at combinations, combining with other checkpoint pathways, including Ipilimumab or CTLA-4 antibodies. You name it, there's all these different combinations. We're also looking at, in the second bullet point, co-stimulatory pathways. So if we take off the brakes and put on the gas of the immune system, can we increase the chance of response to this type of therapy? Also, there's molecules within your lung cancer environment that are also inhibitory that the tumor actually puts off. There's pills actually being developed to block those type of molecules or inhibit those molecules. This is the IDO inhibitor. There's also a myriad of studies looking at, should we combine it with chemotherapy? Should we combine it with drugs like Tarceva or afatinib? And should we combine it with radiation? There is some data that if you receive very focal radiation and you happen to be on this type of immune therapy, then it can increase the response. So we've seen a few patients that happens. Combining it with cancer vaccines, like we originally talked about, this type of therapy might resurrect vaccines. And then lastly, this epigenetic therapy, this is like the software of your DNA, helping with expression or not expression of different genes. And the thought is that if we give some types of therapy called epigenetic therapy, we might increase the expression of abnormal proteins and increase the chance that your immune system might recognize that. So again, the goal of all these trials is really down here. Our job now is to improve on this. We're excited about the response. We're excited about the survival with this type of therapy. This type of therapy is transforming the treatment of lung cancer. However, we're not satisfied. We want to figure out how to have all lung cancer patients benefit from this type of immunotherapy. And I think combinations of therapy, different types of therapy, and really being able to personalize this type of therapy for each patient is really going to be the answer. So thank you very much for suffering through all of this data.